Welcome. If you're preparing for the NCLEX, you know it's more than just a knowledge test, isn't it?
Oh, absolutely. It's strategy, it's critical thinking. It's really about endurance under pressure.
Exactly. Can you apply what you know when things get confusing?
That's the core of it. And our goal in this deep dive isn't just, reviewing content, though we'll do that with gerontology. It's about giving you the strategy for those really confusing multiple choice questions, the MCQD format.
The ones designed to make you second-guess yourself.
Precisely. And we want to make sure you know this material has been put together specifically for you by Dr. Abdul Karim.
Right. The focus here is helping you cut through that potential confusion, focus your efforts, and really learn how to navigate those tricky questions.
It's all about application. Gerontology is such a key area because it pulls together physiology, psychosocial needs, and, critically, medication safety.
So we need to stop thinking about aging changes as just like isolated facts.
Exactly. Think of them as immediate safety alerts, things you need to act on.
Okay, let's unpack that. Where should we start with the foundational physiological changes? Which ones just scream safety risk on the exam?
Well, think system decline, reduced reserve, the integumentary system is a big one, loss of skin turgor, less subcutaneous fat.
Okay, so thinner skin, less padding.
Right. And on the exam, that's not just a description, it's a vulnerability.
Which leads to what specific nursing concerns? Two main ones, I imagine.
Two big ones. First, lower tolerance to heat and cold. They can get dangerously chilled or overheated much faster.
Okay, that makes sense.
Second, the skin is just more fragile, easy bruising, skin tears, so the exam tests if you connect that state to action.
Like teaching them to check their feet, their skin.
Daily checks, yeah, and remembering little details like cutting toenails straight across,
Yeah.
prevents ingrown nails, potential infections, it's all linked.
That's a really practical application point. Okay, moving on to the big one, fall risk. The fall risk duo you mentioned. Neurological and musculoskeletal changes.
Yeah, the connection there is huge. Musculoskeletal changes first, less muscle mass, their steps get shorter, maybe a wider gait for balance.
And that structural shift, kyphosis.
Right, kyphosis, sometimes called a dowager's hump. It can actually reduce their height by inches, and it shifts their center of gravity forward permanently.
Wow. So how does that physical shift interact with the neurological changes we often see?
It compounds the problem. Neurologically, reflexes slow down. And while long-term memory is often pretty good, they might remember childhood vividly.
Short-term memory can decline. Processing speed, too.
Exactly. So you have someone whose center of gravity is off and their reaction time is slower. That's a recipe for instability.
So the nursing priority isn't really fixing the decline, it's adapting to it.
Absolutely crucial, especially with short-term memory issues. The key thing is do not rush them.
Because hurrying them increases anxiety.
Yes. Hurrying during care, instructions. It causes frustration, anxiety, and that can directly lead to losing balance. A fall. If an exam question asks about fall prevention linked to cognitive change, slowing down, being patient, that's often the key intervention.
Got it. Okay, let's round out physiology with cardiopulmonary. The theme seems to be decreased reserve capacity.
That defines it, really, how they cope with stress or illness. Heart valves get thicker, stiffer, maybe calcified. Cardiac output drops.
And the lungs.
Respiratory muscles weaken. The chest wall is less compliant, doesn't stretch as easily.
So less tolerance for exercise or any sudden demand on the body.
Precisely. And this ties directly into infection risk. Weakened respiratory muscles mean they can't cough effectively, can't clear sputum well.
Making respiratory infections like pneumonia much more serious.
More severe, and they often last longer. And here's a key point for novice nurses. You won't always see a high fever. Often, the first sign of a serious infection is altered mental status, confusion.
That's a critical connection. Which brings us perfectly into pharmacology. This is where all those physiological changes really collide with medication management.
Yes, a major safety crisis area, and where the NCLEX loves to test strategy.
Polypharmacy, taking multiple medications.
And it's not just about cost or forgetting doses, though those are issues. The primary concern is adverse effects, toxicity.
Because their bodies just can't handle meds the same way.
Exactly. Less lean body mass, but critically reduced kidney function, lower GFR, they just don't excrete medications efficiently.
Which explains the dosage recommendation, often just 1/3 to 1/2 the normal adult dose.
Right, because the risk of accumulation is so high. Think about a classic NCLEX scenario. A client on digoxin. Narrow therapeutic window.
Okay.
The question asks, What complication results from decreased GFR?
And the distractors might mention things like decreased absorption
Yeah.
or maybe weird side effects.
Exactly. But the strategic breakthrough is knowing decreased renal function means impaired excretion. That's the direct link.
So the medication builds up, it accumulates.
Yes. Decreased GFR equals impaired excretion equals high risk for digoxin toxicity. You have to make that direct connection. Forget absorption issues in this context. It's about getting rid of it.
That shift focusing on excretion, not just absorption. That's a key strategic insight. Okay, what about prioritizing? When you get a new older client, maybe overwhelmed with meds, polypharmacy, what's the absolute first nursing step?
This tests your grasp of the nursing process sequence, logic, before you dive into checking interactions, before you even think about calling the provider.
You need to know what they're actually taking.
Precisely. Your priority assessment is determine if there are medication duplications. Are they taking the same drug or similar drugs, prescribed by different doctors, maybe 2 different pain meds? Clean up the list first.
That makes perfect sense. Inventory first, then analysis. And speaking of conflicts,
Yeah.
what about those high-risk drugs? The Beers criteria one.
Ah, yes. Critical safety point. If an older client shows a sudden, unexplained change in mental status confusion, agitation, you must suspect an adverse drug reaction or toxicity first. Rule it out.
And be aware of specific meds.
Definitely flag meds on the Beers list. Things like indomethacin, meperidine, older antihistamines, benzodiazepines. These often pose more risk than benefit in older adults. Might need to question that order.
Okay, let's shift gears now. Psychosocial concepts. These questions feel different, less physiological, but they test our ethics, our ability to promote quality of life. Autonomy.
Yes, autonomy is huge. Older adults often fear losing control. Autonomy is just that. Personal freedom to direct your own life.
So an NCLEX question on promoting autonomy. The strategy is to pick the answer that leaves the decision with the client.
Exactly right. Things like the nurse planning all their meals or setting a rigid schedule, even with good intentions, takes away their power.
So the better answer involves choice.
Always. Allowing the client to choose their social activities, deciding when they have visitors, things like that, reinforce their control over their own day.
Makes sense.
Yeah.
Okay, how about coping with loss? It's sadly common. How do we identify effective coping on the exam?
Look for positive engagement. Active processing of grief, not avoidance.
So ineffective coping would be things like neglecting hygiene, isolating.
Yes, neglecting personal grooming, refusing to leave their room, shutting down socially. Effective coping looks different. Maybe looking at old photos, visiting a gravesite, participating in a senior center program. They're connecting, remembering, not avoiding.
Got it. This section also often tests distinguishing between the 3Ds, right? Depression, delirium, dementia. Always confusing.
They can be easily confused, which is why the NCLEX tests it. We need to be clear. Depression, often slow onset, maybe worse in the morning, but crucially, their level of consciousness, their alertness, is usually normal.
Okay, slow onset, normal alertness, then delirium.
Delirium is an acute medical emergency. Sudden onset, fluctuates wildly, often much worse at night. That's classic sundowning. And key difference, a reduced or distorted level of consciousness. It's usually triggered by something physical, UTI, infection, drug toxicity.
Sudden, fluctuating, altered consciousness, got it. And dementia.
Dementia is also usually insidious, slow onset like depression. But once it's established, the symptoms are relatively stable day to day, unlike delirium's fluctuations. Consciousness is generally normal, but they have profound trouble with cognition, especially language finding words.
Slow onset, stable symptoms, normal consciousness, but trouble with words. Differentiating is vital for proper care.
Absolutely. Treating delirium like dementia or vice versa is dangerous. And remember, regardless of the cause of distress,
Any suicide threat is serious.
always take it seriously, treat it as a high priority safety risk, no matter the age.
Okay, final major area. Safety, potential abuse, and our role as nurses. If the NCLEX asks you to identify a client most at risk for abuse, what's the profile?
Look for vulnerability and dependency. The typical profile is someone of advanced age, few social supports or contacts, and critically, a physical or mental impairment that limits their ability to perform activities of daily living, their ADLs. Dependency is key.
So the strategy is spotting the most defenseless person among the options.
Exactly. Someone with, say, advanced Parkinson's disease would be at very high risk. They're dependent, mobility is limited, maybe cognitive changes too.
That makes sense. Now, what's the nurse's immediate action if abuse is suspected? Maybe the client confides, or you see unexplained bruises.
The sequence is critical here and legally mandated in most places. First, Assess thoroughly. Provide confidentiality to the extent possible, but explain you may need to report. Then you must report the suspected abuse to the appropriate authorities. Follow your state laws and agency policy.
Reporting comes before anything else, like offering resources.
Reporting is the immediate mandated action. Then you help the victim develop a safety plan, fast escape route, hotline numbers, secure important papers, that kind of thing.
And what about situations where it seems like caregiver burden is the issue, not malicious intent?
That's where suggesting appropriate, non-judgmental resources comes in. Things like respite care, support groups, senior centers. Addressing the stressor can help prevent future neglect or abuse. It's about support, not blame.
Okay. And one last safety reminder, tying back to physiology.
Yes, remember the subtle signs. Because older adults might not spike a fever or show typical infection signs, always consider that altered mental status, sudden confusion, agitation could be an infection, especially a UTI. Keep that high on your suspicion list.
We've covered a lot of ground, really specific strategies. Let's quickly recap the core takeaways. Connect physiology, like low GFR, directly to med risk, specifically toxicity from accumulation.
Right, and prioritize nursing actions logically. Check for med duplication before digging into complex interactions.
And always promote autonomy. Let the client make choices whenever possible.
That's it. Success comes from applying that critical thinking to the confusing options. That's exactly what Dr. Abdul Karim wants for you with this material. You know the content, use these strategies to navigate the test.
Great. So here's a final thought to chew on. We mentioned that older adults might have decreased pain awareness, or maybe they're just hesitant to report it, thinking it's just part of getting old. As a new nurse, how will you advocate for good pain management beyond just asking, are you in pain? How will you look for those nonverbal cues, restlessness, agitation, changes in function, to make sure their pain is truly addressed?
That's a really important challenge for practice. Vigilance beyond the verbal report.
Something to keep thinking about as you prepare for that next big step.